Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hi, I'm Dr. Matthew Davids, Director of Clinical Research for the Division of Lymphoma at Dana-Farber Cancer Institute and an Associate Professor of Medicine at Harvard Medical School in Boston. I'd like to welcome you to this Highlights and Hindsight in CLL. During this presentation, I will be describing the most significant ongoing studies and publications in CLL from 2024, and will detail their impact on the treatment continuum. Let's get started. We had a number of different practice-changing studies that were either published or presented in the 2024 time period, and I think I would divide this up mainly into the frontline treatment options, as well as relapse refractory treatment options, and then Richter's syndrome. And so we'll address each of these sections, starting with frontline treatment. At the 2024 ASH annual meeting, we saw the first presentation of the phase 3 Amplify trial, a randomized study in the frontline setting comparing acalabrutinib venetoclax versus acalabrutinib venetoclax and obinutuzumab versus a control arm of chemoimmunotherapy with FCR or BR. Both of the acalabrutinib venetoclax-based combinations provided deep and durable responses with manageable safety profiles. And AV is the first all-oral fixed-duration regimen containing venetoclax with a second-generation BTK inhibitor. In the Amplify study, the median follow-up reported was about 41 months, and both of the AV-containing regimens provided a statistically significant improvement in IRC-assessed progression-free survival compared to the control arm. The median PFS has not yet been reached for either of the AV-containing arms, whereas it was 47.6 months for the FCR-BR arm. The estimated 36-month PFS rates were 76% and 83% for AV and AVO, respectively, compared to 66% with the chemoimmunotherapy control arm. Also, there was an overall survival advantage of the AV doublet over FCR and BR with a hazard ratio of 0.33. I believe this will likely be a practice-changing study if it leads to regulatory approval for AV and possibly AVO in the US. However, the Amplify study did exclude high genetic risk CLL patients with TP53 aberration. For those patients, I presented data from our AVO triplet study, an investigator-initiated phase 2 study from Dana-Farber, which is a single-arm study exploring this triplet in a population of patients enriched for high-risk disease. Actually, 63% of the patients in our study have high-risk TP53 aberrant, previously untreated CLL. And we reported a 71% rate of undetectable minimal residual disease in the bone marrow at 10 to the minus 4 at cycle 16. This is an MRD-guided therapy where patients could get a 15-cycle or 24-cycle course of treatment depending on their MRD status at the end of each time period. Using this approach, the responses have been durable. In the non-TP53 population in our study, 88% of patients were progression-free at 4 years. And in the TP53 aberrant population, it was a 70% 4-year PFS rate. Our data certainly do support the use of AVO as a triplet therapy in these high-risk patients as we await data from randomized phase 3 trials, such as the German CLL16 trial, which is comparing the AVO triplet to venetoclax obinutuzumab in the high-risk population. And I'll note that our AVO presentation was subsequently published in the Journal of Clinical Oncology recently. Now let's talk a little bit about time-limited. We've talked a little bit about time-limited. Now let's talk about continuous BTK inhibitor-based strategies for CLL. We're fortunate to have multiple different covalent BTK inhibitors, and one of which is called zanubrutinib. And this drug has previously been explored in the phase 3 Sequoia trial in the frontline setting, where patients were randomized to continuous treatment with zanubrutinib versus the time-limited course of bendamustine and rituximab. In this randomized cohort, patients did not have high-risk deletion 17p, and we had previously seen earlier results of this study suggesting a PFS advantage of zanubrutinib. At the 2024 ASH meeting, we saw for the first time the 5-year follow-up of the Sequoia study, and importantly, the PFS benefit of zanubrutinib was sustained regardless of IGHV mutational status, and depth of response in terms of complete remissions continued to improve with ongoing therapy. The 5-year PFS for zanubrutinib in SEQUOIA is 76%, which is comparable to what's been observed with acalabrutinib in other trials. The safety and tolerability of zanubrutinib has also been consistent over longer periods of time with prior reports, with no new safety signals identified, and relatively low rates of atrial fib flutter and treatment discontinuations. So I think this was a very helpful data set that provides long-term confidence that we can use zanubrutinib as an effective continuous treatment option in the frontline setting for CLL. Next, I'd like to highlight some updates from the Captivate trial. This is an important study that we've seen presented and published now several times, and it's a phase 2 multi-center study of ibrutinib plus venetoclax as an all-oral, once-daily chemotherapy-free fixed-duration regimen for frontline CLL. We previously also seen updates from an MRD-guided therapy cohort, but at the 2024 ASH meeting, we saw updates from the fixed-duration cohort where these patients got a total of 15 cycles of therapy. One of the things that was really interesting about this updated presentation with about 5+ years of follow-up now is that they looked at the response in patients who had enlarged lymph nodes at the beginning versus patients who had smaller lymph nodes at the beginning of the study and found that the results were quite similar. They also saw that long-term progression-free survival most strongly correlated with undetectable MRD status, while depth of response, such as CR or PR, had less of an impact. And so that was very interesting. I would say also the safety profile of this combination of ibrutinib venetoclax does look good in the younger fit patients and was similar irrespective of lymph node bulk at study entry. They also did an analysis of overall survival in patients receiving fixed-duration ibrutinib plus venetoclax-based therapies on this Captivate study, as well as patients pooled from the GLOW study, which looked at older patients. And they looked based on different subpopulations of patients based on their age, greater than or less than 65, based on markers such as IGHV status. And one of the really interesting findings from this abstract is that the overall survival was comparable across the ibrutinib plus venetoclax treated patients compared to an age-matched European general population without CLL. So I think it really suggests that our therapies are getting so good now in CLL that we can help especially these older patients to achieve a similar lifespan as patients who don't have CLL. We also saw earlier this year at ASCO and the EHA meetings with 5.5 years of follow-up that the fixed-duration regimen in the Captivate study, ibrutinib plus venetoclax, continues to provide durable benefit. We noted in these abstracts that the median progression-free survival has still not even been reached now with 5.5 years of follow-up, and the 5-year overall survival rate in Captivate is 96% for all treated patients. They did look at the subgroup of patients with high-risk genomic features like deletion 17p or TP53 mutation, and there the overall survival is a bit shorter at 90%, but certainly overall very favorable for that high-risk group. Additionally, they looked to see if patients who achieved undetectable MRD in the blood or bone marrow had improved outcomes in terms of durability of response, and that was indeed the case. So, for example, patients with undetectable MRD in the bone marrow 3 months post-end of treatment had a 5-year progression-free survival rate of 84%, compared to only 50% for those small number of patients who did not achieve undetectable MRD at end of treatment plus 3-month bone marrow. We also saw updates from the phase 3 GLOW study at ASH 2024. This is a time-limited combination of ibrutinib plus venetoclax in an older population of patients with comorbidities and was compared to a control arm of chlorambucil plus obinutuzumab. We've now seen 64-month follow-up of the GLOW study, and ibrutinib plus venetoclax continues to show superior progression-free survival, a reduced risk of requiring second-line therapy, and a sustained overall survival advantage over chlorambucil plus obinutuzumab. With additional safety analyses as well, this is reassuring that patients who kind of make it through that first, more difficult year of treatment can have a prolonged survival time. But I will caution that there were still significant toxicities observed with ibrutinib plus venetoclax in the first year in this older and frailer population. And right now, this drug combination does not have approval in the United States for that reason, although it is approved by the European Medicines Agency. So let's change gears now and talk about relapsed refractory CLL. Just to briefly review, the non-covalent BTK inhibitor pirtobrutinib was previously shown in the Bruin phase 1/2 study to be highly effective for patients with prior exposure to a covalent BTK inhibitor, regardless of whether patients had progressed or come off that covalent BTK inhibitor due to toxicity. The overall response rate in that original Bruin study was in the range of 73%, and when including patients with partial response and lymphocytosis, it was actually 82%. And the median progression-free survival was published as 19.6 months in a very difficult to treat population, many of whom had also had progressed after prior venetoclax. At this year's ASH meeting 2024, we saw for the first time the results of the phase 3 Bruin CLL 321 trial. This study is of note because it's the first randomized study that's been conducted exclusively in covalent BTK inhibitor pretreated CLL and SLL patients. These patients were randomized 1-to-1 to either continuous treatment with pirtobrutinib or to investigator's choice of the PI3 kinase inhibitor idelalisib given with rituximab, or to 6 months of bendamustine and rituximab. This was a heavily pretreated study population with a poor prognosis, and pirtobrutinib was found to significantly improve progression-free survival compared to that control arm, and additionally had a more favorable safety profile. The updated analysis that was presented now with a median follow-up of just under 1 year showed that the hazard ratio by IRC for PFS was 0.55 in favor of pirtobrutinib over the control arm. The median PFS for pirtobrutinib was about 14 months compared to 8.7 months with the control. I think for me, what was most impressive about this abstract was the time to next treatment or death with pirtobrutinib, which was about 2 years, and actually close to 2.5 years in patients without previous venetoclax, suggesting that even minor progression events early on can still allow patients to proceed with pirtobrutinib treatment and benefit from it for several more months after minor progression events. These PFS advantages of pirtobrutinib versus the control applied across different subgroups, including those patients with prior venetoclax treatment, complex karyotype, or high genetic risk CLL with TP53 aberration. And the study also confirms in a larger subset of patients that the tolerability of pirtobrutinib continues to look quite good. For example, the AFib rates in the Bruin CLL 321 trial look similar to the control arm, suggesting that pirtobrutinib does not significantly increase the risk of that arrhythmia. We also saw data at the ASH meeting updating us on the BTK degrader drugs, which continue to look quite promising. I'll briefly review both of them. So the first is BGB 16673, which is a CDAC molecule that induces BTK degradation by binding specifically BTK and E3 ligase. This catalyzes the transfer of ubiquitin molecules to BTK, which marks the protein for destruction by the proteasome. We'd previously seen preclinical models where BGB 16673 was able to effectively degrade both wild-type and mutant forms of BTK that are associated with resistance to the other inhibitors of BTK. So at the ASH meeting, we saw the update to the Cadence 101 study, an ongoing phase 1/2 trial that's first in human study looking at BGB 16673 as monotherapy in relapsed refractory B-cell malignancies. The emerging data from this first in human study continue to show a nice safety profile, as well as promising and deep overall responses, particularly in the heavily pretreated patients with relapsed refractory CLL or SLL, including those who've had prior covalent and non-covalent BTK inhibitors and those with BTK resistance mutations. The updated overall response rate was 78% in 49 response-evaluable CLL patients. And importantly, this included some patients who had progressed after BTK, BCL2, and non-covalent BTK inhibitors. We also saw very promising study data from another BTK degrader, NX-5948, which was also presented at this year's ASH meeting, and also demonstrated very promising efficacy and safety data in a very difficult to treat population. In 30 response-evaluable patients with CLL, the overall response rate was 76%, and they noted many patients with BTK or even PLC gamma-2 mutations who responded to NX-5948. A notable aspect of this trial also is that it allowed patients with CNS involvement, which is a rare complication of CLL, but they also reported responses in these patients, which is encouraging. We've also seen recently the development of immunotherapy for CLL, which is a very new area for this disease. And in particular, we've seen now data from a bispecific antibody, epcoritamab, which is a CD20, CD3 bispecific that's been FDA approved now in other B-cell non-Hodgkin lymphomas and is now being explored for the first time in CLL. We know that patients who are double refractory to covalent BTKI and the BCL2 inhibitor have limited treatment options and short overall survival, and that CAR T-cell based therapy so far has only offered complete remission in a minority of patients. And epcoritamab is being explored now in the EPCORE CLL-1 trial, and single agent activity is actually quite encouraging. And we saw the updated data at this year's ASH meeting showing that the CR rate is now close to 40% in this population of patients. And some of the immune-mediated toxicities that were seen early in the study have now markedly improved as they've developed an optimization cohort where they've adapted to a different step-up dosing schedule and really have seen only low-grade cytokine release syndrome and no ICANS since making this change. So I think this is a very encouraging development. The numbers of patients treated are still quite small, about 23 patients with efficacy data, but a number of patients have recently come on the study. And so as the data continue to mature with larger numbers of patients and longer follow-up, I'm really curious to see how the durability of the bispecific antibodies look for relapsed refractory CLL as a potential way to justify moving these drugs into earlier lines of therapy. Early in 2024, we had the first FDA approval of a CAR T-cell product for CLL. This is the lysocaptogene maraleucel product, or liso-cel, which is a CD19-directed autologous CAR T-cell product, which is approved for patients with relapsed refractory CLL or SLL who have received at least 2 prior lines of therapy, including a BTK inhibitor and a BCL2 inhibitor. The data for the approval came from the Transcend 004 trial, a phase 1/2 study of liso-cel, which assessed rates of CR as the primary endpoint. The CR rate was in the range of about 20%, and the median duration of response of those who achieved the CR was not reached. And so I think those initial results were encouraging and certainly enough to lead to the initial approval. But on the other hand, they do leave room for improvement with that CR rate. And so excitingly, at the ASH meeting this year, we saw an update to the Transcend study, which looked at a separate cohort of patients who received ibrutinib-based therapy contemporaneously with CAR T-cell-based therapy. And it did seem that by using this combination, the efficacy was enhanced of the CAR T product, with a 45% rate of CR observed with the combination. The safety profile overall looked pretty similar, so I think it's very intriguing to consider using a BTK inhibitor with liso-cel in clinical practice. I think we do need to be cautious about comparing between these different cohorts. This was not a randomized comparison, but I do really think that this is a promising new strategy to potentially enhance the activity of CAR T cells without adding significant toxicity. Richter's transformation remains a very challenging problem for patients with CLL. It occurs probably in about 5 to 8% of patients with CLL throughout the course of their lifetime, and the prognosis has historically been quite poor, with median overall survival with existing treatments only in the range of about 6 to 12 months. So there's a new data set that's been emerging over this past year that was published recently of a PD-1 inhibitor, tislelizumab, given in combination with the BTK inhibitor zanubrutinib for 12 cycles. In this study, patients who were responding were able to undergo maintenance treatment with both agents. And in total, they treated 48 patients, and 28 patients had a response, so an overall response rate of 58%, including about a 19% complete response rate. This met the study's primary endpoint, and a variety of the secondary endpoints have also now been reported. For example, the median progression-free survival is in the range of 10 months, and the median overall survival was not reached, with about a 75% 12-month overall survival rate. It's certainly favorable compared to historical data sets with other regimens. This has generally been a pretty well-tolerated regimen. We do see infections, as is common in our patients with CLL or Richter's, gastrointestinal side effects, and hematologic toxicities. But I do think this is a promising combination of a PD-1 blockade with BTK inhibitor, and this is now being explored in a phase 3 setting that's going to be opening in a large study in Europe relatively soon. Now, epcoritamab, the CD20/CD3 bispecific antibody approved in many different lymphoma subtypes now, is also being studied in Richter syndrome. And we saw data from EHA 2024 looking specifically at a cohort of patients from the EPCORE CLL1 trial with Richter transformation. These were 35 patients with Richter transformation who received epcoritamab as treatment. In the response evaluable population of 26 patients, the overall response rate was 50%, and the CR rate was 35%. And when patients were subsetted into those who had not had prior treatment for Richter's, the responses looked even better, with an overall response rate of 62% and a CR rate of 54%. So I do think that this is a promising approach for Richter transformation as well. There's other studies now underway looking at different bispecific antibodies, such as glofitamab, in this population. And so I think these could be good building blocks to develop even combination regimens of bispecific plus small molecule, for example, to even further enhance the treatment for Richter's patients. So in terms of the data for frontline relapsed refractory and Richter patients, I would say that we're sort of at a really important inflection point now in CLL, particularly I'd say in the frontline setting where we've been kind of used to the idea of using continuous treatment with BTK inhibitors, or if we needed to use a time-limited therapy to have venetoclax with obinutuzumab. And I think particularly with the Amplify study reading out and likely leading to approval of the AV doublet in the US, it's going to be very helpful to have an all-oral time-limited regimen for our patients. And I think this will further move the field toward the time-limited treatment approach and away from continuous BTK inhibitor therapy. Now, that being said, I think there will still be a role for continuous BTK inhibitor therapy based on the convenience and the long-term durable responses that have been observed. This does have implications, I think, in terms of moving toward the time-limited therapies in terms of the relapsed refractory CLL setting. In particular, I think it's going to be very important to generate prospective clinical trial data on retreatment strategies, because if patients have a time-limited venetoclax-based option for frontline treatment and enjoy a long response, it's very likely that they would be able to benefit from a time-limited venetoclax-based treatment option a second or even a third time. And I'm hopeful that by developing these more effective time-limited combination approaches, we'll actually even be able to reduce the risk of Richter transformation developing. And if we do have patients who still develop Richter's, being able to treat it more effectively, particularly with some of the immune-based mechanisms we've discussed. One other perspective I'd like to provide is on the role of mutations in guiding therapy decisions. At the ASH meeting, we saw a meta-analysis which incorporated data from both clinical trials and real-world studies that confirmed that BTK and PLC gamma 2 mutations are present in the majority of patients with CLL who develop progressive disease while being treated with covalent BTK inhibitors. Interestingly, though, in this analysis, over a third of patients actually did not harbor such mutations, which does indicate that there's probably other resistance mechanisms that have not yet been fully investigated, whether they're genetic mechanisms or functional resistance mechanisms. I think this highlights to me that there's still a lot of work that needs to be done to better understand resistance to these commonly used treatments for CLL. So in terms of my key takeaways over this past year, as well as my recommendations for clinical practice, I would say in the frontline setting, as I said before, many patients are on continuous covalent BTK inhibitor-based therapy, and that is a very effective approach, but it does require long-term treatment, which has ongoing risks and side effects and costs. And so I do think that with the development of the all-oral time-limited regimens like acalabrutinib and venetoclax, that we may be able to convert more patients to these time-limited therapies. And the triplet therapy with AVO also supports the use of that type of more aggressive combination for patients who have high genetic risk CLL, such as TP53 aberration. In the relapse setting, we have lots of new options that are coming along. Some of them are in very early phases of development, like BTK degraders and bispecific antibodies. But some of them, like pirtobrutinib, already have approval and are going to be used more and more in the relapse setting. The Bruin 321 study is also registrational, as it's designed to lead to full approval of pirtobrutinib in the relapse setting for CLL. And depending on exactly how that label reads out, it may facilitate using pirtobrutinib in earlier lines of therapy, for example, the second line setting. And it's great for our CLL patients to have so many good options. particularly with pirtobrutinib, given its favorable safety profile, I do think that is a major advantage of that drug. And I think as we continue to help our patients to personalize their treatment decisions, taking into account the side effect profile of these drugs is quite important. So overall, I would say it's been a very productive year for CLL clinical investigation. We have a number of new regimens coming online in the clinic and a number of other regimens and exciting new mechanisms that are in development and likely will move into later phase trials in the coming years. So although it's always challenging to have CLL, there's really never been a better time to have this disease. And I'm optimistic that outcomes will continue to improve for our patients over time. Thanks for joining me. And please refer to the landing page for the slides from this presentation and to claim your CME credit.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.